Ulrika heter jag. Jag ska prata om wilderness medicine som är en subspecialitet i akutmedicin, emergency medicine i USA. Det är ingen tenta, man får ingen liksom board exam, men det är ganska populärt för att det är en häftig subspecialitet med många häftiga erfarenheter, och min och Jazz kollega Fred Chu, and I'm going to switch to English because I can't do both Swedish and English. He did a wilderness medicine fellowship, and he has been my biggest source of inspiration for this talk. As opposed to my previous talk in addiction medicine, emergency medicine, I was like, wow, I have like so much to say. Can we make this a 4-hour lecture? Like, I don't know how to talk about my entire life in an hour. This is more me being an enthusiast. And my claim to fame is that I have arranged a couple of trips with my friends, a larger group of people, but I have not really led like a mountain climbing expedition or things like that. This is taken from my camping trip last year, this picture. And we went to Eastern Oregon, kind of high desert, and this beautiful river that runs through it called John Day. And there was, it doesn't really show on the picture, but this really cool double rainbow that went from sort of horizon to horizon. And this was another trip that I was sort of the unofficial medical responsible person for. I know a lot of my friends have been rafting guides, whitewater rafting guides, for a part of their 20s into their early 30s. They are no longer. They're working a desktop job and want to get out a couple of times a year. So we all pulled together a group of people. So we were about 30 geriatric millennials who wanted to like relive our 20s again. I did not know all these guys personally, and we drove out to Hell's Canyon National Recreational Area and rafted for 6 days, which is not that huge of a trip, but still 30 people out in the wilderness who are all just by a computer on the daily basis. Things can happen. So I made some preparations. Okay, we're going off. What's it called? This is not a good time for my computer to freeze up. Well, whatever. Anyhow, I didn't really know about 50% of the people attending this trip personally. So I took a little bit extra time to sort of snoop around and learn, because I did not want to be the sole medical person in this group of people if something was to happen. And just for context, looking at Google Maps doesn't really give you a great view, but this is largely how most of this canyon looks. Oh, I have this in my hand. Okay, multitasking. So it's not great for a rescue operation. Pretty steep down into water. You can definitely be stupid and climb, and you can also raft. This time of year was right after snowpack melt, and we had 5 class 3 rapids to go through, which is like one of the biggest ones. And we flipped a bunch of boats, and we all survived, but it was good. I have also... I'm just humble bragging about my cool rafting trips right now. I went to another trip, pretty similar setting, Gates of Lodore. Also not great for rescue operation. We rafted from Colorado into Utah, and it was gorgeous. This is also high desert, even warmer because we're sort of Colorado, Utah climate. Rattlesnakes, all of it. And most of my inspiration for this talk comes from really 2 books that are like the main teaching books in the field. One is Advanced Wilderness Life Support, and the other one, which is like the Bible for wilderness medicine, is Auerbach's Field Guide to Wilderness Medicine. And I have supplemented for a little bit more updated knowledge and evidence-based knowledge from MRAP's Core Pendium. I'm just curious, how many have used their Core Pendium from this pay-for-service podcast that I have absolutely no affiliation with? I have no disclosures to give. I didn't even make a slide of it. I wish I had. Has anyone heard of it? No. Okay, so MRAP is a podcast. I'm sure a couple of people may have heard of that. And they have written sort of a textbook. And I find it hugely helpful. and I have drawn a lot of the more updated medical information from there. So if you've read a bunch about cold-related injury and heat-related injury in the Compendium, you can go and grab a coffee. Anyhow, so my goals and objectives. First and foremost, honestly, the biggest thing with going on a trip is just packing. Not super sexy, but also like if you didn't do that, everything else kind of falls apart. So the real deal wilderness medicine books, they have an appendix with a packing list that is 40 pages long. Like that will prepare you to set up a base camp at Mount Everest. I don't really know, maybe some of you do. Have anyone like had a major medical operation? Like in sort of a, I'm looking at maybe Nicholas, maybe you have some like set up the tent. Right. And then there's sort of a structure for that. Like you don't have to write that packing list yourself. So anyhow, I figured maybe not all of us is going to go out there and climb Mount Everest, but a lot of us is probably going to do an extended trip far away from hospital and care. So I kind of put together my own little packing list. I also want to just briefly go over lightning injury, hypothermia, drowning, and heat exhaustion versus heat stroke, which I felt obliged to include after training in Miami for 3 years. I also want to just check in on shoulder reduction because it's kind of fun. And the lateral camphotomy because you can actually provide a life vision saving procedure with something you might already have packed. Just a little check in on that. Okay. We'll see. Hopefully we'll get through this. So this is like the basic stuff to cover. Honestly, this is like the first 30 pages of the book, which is a little disappointing because it's really just the things that like my mom and dad could have told me that I should have packed. I'm not really going to dive into all of this because there are better packing lists written about this. I'm going to focus more on sort of the medical piece of it. But I guess one piece of it is the insulation to make sure that you have something that you can insulate the patient with from above and below type of thing. So a little sort of mental note on this one. My computer is like having some stage fright here. All right, good. So yeah, it's all about the packing part. And my medical prep list, honestly, something I myself forgot to pack properly was kind of just PPE. I wish I would have had just a couple of pairs of gloves. Somebody had a pretty superficial scrape, but a little bit of tattooing of just debris in the wound. And it was like, well, should we like repurpose somebody's toothbrush or like how can we do this? I just wish I would have had a clean way to kind of debride the wound with just some clean piece of cloth, and I totally forgot gloves. Of course I did. But I did remember my antiseptic and I did have a change of clothes and I did think about that, but just the gloves were so obvious, like you just grab them when you go into a room, and I guess I forgot that. And also think about packing everything accessible for an emergency. That the most experienced climber might carry the kit, that the last boat in the group carry the medical kit, so you don't have a kit downstream when you need it upstream, because that's not going to happen. So a lot of it is just like thinking strategy before you do it. Also consider, obviously, endemic infection. Going to a place with malaria, probably add that to your antimicrobial list. If you're going altitude, if you're going extreme temperatures, that's going to be kind of written all over the place. But also what I found is to kind of subtly ask people to maybe disclose a little bit of their medical history. If there is somebody with a seizure disorder that they think, you know, oh, my best friends know it. Or if they're taking something else, especially if it can cause discontinuation symptoms from abruptly stopping it. And maybe they remember to pack it, but they might drop it or lose it. I actually, like, casually, the night before we were going to travel, heard a guy that I haven't really met before, that was a friend of a friend. He was talking about approximately how much THC he would do in edibles. And I was like, wow, that is an ungodly amount of cannabis. Like if you drop this in the river, you're gonna go through terrible withdrawals. Like I'm not gonna have that. I don't have that much Zofran. So I made him split up his stash and put it in 2 different ammo cans on 2 different boats in case part of it would sink, because I just didn't want to deal with that. And he was like, oh wow. That was like a little reality check on him in terms of how into those gummies he is. But you never know. Anyhow, the PPE part, um, just bring it, just bring it. I felt like this person when I was sitting there with my hands, just like, yeah, I'll try and just scrape it a little bit there. And next part of this packing list, this is what I condensed down from the really exhaustive appendix. I'm not going to read this out loud because I feel like you all get an idea for it. But I think the topical skin protectant, super important, either for heels, for hands. I brought like a Dermabond, and we used that for like the rowers, really the people that were the strongest in the group. Sometimes there was not like I could switch out rowing, and we had to have this person rowing and the gloves were chafing or got lost in the river or whatever. So great to have a way to protect broken skin. That's like a first and foremost. This is my kind of basic list of antimicrobials. Of course, direct this towards where you are. I added Lyme disease, which is Borrelia, to this list because I know it's endemic here. It is not in the Pacific Northwest. But yeah, this was just what I thought would kind of have a basic coverage for stuff that I anticipated could happen. And also, if you need malaria stuff, definitely bring malaria stuff. And I have a little list of gastrointestinal stuff. I brought ondansetron and I brought meclizine, thinking somebody would maybe get seasick. Actually, I should have probably, if somebody gets really sick, it could be helpful to have a suppository if you have no oral options whatsoever. And I had some electrolyte replacement powder. Pedialyte is like the brand name in the US. And this is my trauma packing list. Be nice to have a tourniquet. It's also nice to have some wound packing, a couple of trauma shears, splint material if you can carry it. For us, it was pretty nice because the river was going to carry our stuff. So I did bring like a super basic splint because everything on the boat is floppy. Like we don't have any, I don't know, everything is like rubber and just ropes. So I did bring like just some basic things to splint up a fracture with, because it would take us, there was no other way to get out. When we went into the river, there were no other access point to beyond those mountains you saw before until we rafted down the river. Tops, if somebody got sick, we could probably have done it in 3 days if we started 7 a.m. and dug out when the darkness fell. But it's a long time to go with a severe injury, so that was not really an option. Again, Dermabond, maybe even a little stapler. And I would say a suture kit just for the tools because it's handy to have. And that's pretty much it. I would have wished EpiPens weren't so expensive. We did not have anyone with severe like anaphylactic allergy, but definitely make sure that somebody, even with a remote, like, oh, it happened once when I was a kid, like just bring it. Don't take that chance. People can get pretty laissez-faire with it as time goes and they think they haven't done it in a long time. And then just some extras. You never know what you need. And yeah, that was pretty much where we went, which is fun. Okay, switching over to lightning injuries. This is such a weird topic. Has anyone had a lecture on this before? Has anyone covered this? Okay. Actually, when I read about it, I was really surprised to learn that it isn't that uncommon. There is like at least 30 to 40 deaths from lightning. Yeah, 30 deaths in the United States a couple of years ago when the last data was published, which is kind of a lot because I thought it was like a thing that never happened. Fun fact, lightning is 4 times hotter than the sun. That seems pretty severe. And you can either be injured by, today's understatement, direct electrical injury, being hit by the lightning. You can get a splash from an object, like the lightning actually jumps onto you. You can be in direct contact with something, or you can have a flash over the skin, meaning that electricity doesn't conduct through the core of your body, but rather so over moist, sweaty skin. And you can get it through ground current. A pair of boots with rubber sole is not enough to help you. And you can also actually get blast injuries from there, like ruptured tympanic membranes or trauma from being thrown from the really loud bang. I'm not even going to try and explain the physics about the lightning and then the thunder, but there is like an explosion. Let's just keep it to that. If somebody feels like getting into the details, please stand up and enlighten me. No pun intended. I told myself I wouldn't say that. Okay. I have too many slides. Oh, did I change the slide? Okay. I'm trying to swing like my cheat sheet speaker notes and this. Anyhow, if you have a cardiopulmonary arrest, the cardiac arrest kind of comes from the heart just being defibrillated at the wrong time, right? That's not good. And it also stuns it for longer just because the electrical current is so incredibly strong, but the automaticity of the heart, the intrinsic beating of the heart, will resume in most cases. It can also cause respiratory arrest because it stuns the part of the medullary respiratory center in the brain, and that can cause a secondary cardiac arrest from anoxia. But that also typically resumes. The cell sort of sorts everything out and gets back on track. It can get pretty severe neurologic injury. And also there is definitely sequela from this that can be lifelong. Seizure, confusion, dizziness, deafness, blindness, actually board question nerdiness. You can have delayed cataracts of your eye, of your lens, because it coagulates the heat and the injury from the electricity can coagulate the lens in your eye. And musculoskeletal, anything that comes from like a blast trauma, burns, fracture, dislocation, all that, skin wounds. And in this situation, that actually puts a little twist to our trauma assessment because usually, let's say you come to the scene of a lightning injury, a typical sign would be signs of things that are burned, singed, objects thrown around, and multiple people being in various stages of unconsciousness. And usually if you come to a mass casualty incident, being just a doctor, then 2 people is a mass casualty incident because it's more than you can handle at one time. Then we would move on from what we call a black patient, an apneic patient that doesn't respond with a jaw thrust or simple airway maneuvers. Then you move on to save the next person. But in this situation, if you have the capacity, the patients who are kind of black tagged actually have pretty good prognosis. If you support them with CPR and you perform the airway maneuvers that you have within your means that you can do, the automaticity of the medullary center of the brain and the heart can actually come back. So it's not one of those you're zapped and the tissue is dead. It's just sapped and stunned. And I think that's good to remember. I read that the standard of care according to Auerbach, it's still to perform about 30 minutes of ACLS, CPR on the patient before you can call it if the patient doesn't have ROSC during that time. That's pretty much it. And anyone knows what these guys are called? Nerdy. Board question again. So this is pathognomonic. Said that right? No? For lightning strike, it's this furning of the skin. Does this have a name in Swedish that everyone's like, oh, I'm not going to say that because she's thinking of something in English. So this is called Lichtenberg's figures, and it's because the electricity, it looks like lightning, right? So this is how it strikes the skin and burns the skin. This will actually go away. It's not going to permanently tattoo you, but you will have it as like a grade 1 superficial burn until it heals. Okay, so this is an X-ray after a lightning strike. What do you think could be going on? Just throw it out and I'll repeat it back. Louder so I can hear. Muscle spasm. Great idea. Perfect. Yeah, because the X-ray doesn't look that crazy. And the patient has pain, No clear deformity, but kind of limited range of motion. They say they can't really move their arm. Where is your mind flowing, going? Yes, thinking posterior dislocation. Okay, so this is going to mess you up at some point in your career as well. I've already been there. There is not a whole lot of deformity, especially in people that are a little chunky back here that have some muscle or some fat. Like the posterior dislocation is not very impressive. And it is a little bit less, like it can come traditionally after seizure or lightning strike. That's like the board question. But it can also happen after a fall. My only claim to fame, I've reduced this one time. How many people feel like that they've done this a bunch of times? Okay. Oh, cool. How easy was it for you to reduce? Really hard? Okay. So I was really lucky. For me, it was actually quite easy. But it was also a person who had dislocated multiple times. So I think I cheated. So this X-ray, my point is that it looks honestly kind of good if you glaze over it and you don't think about the mechanism of the trauma. Then it kind of looks okay. But next X-ray, do you see this really nice, the yellow elliptical structure has a overlapping bone elliptical structure underneath, and that is not what we had before. This is occluded. There's not like a clear elliptic structure, and that's sort of the first hint apart from the missing range of motion that something might be wrong, that might be dislocated. And also super hard if the lightning strike had posteriorly dislocated both shoulders, getting the view on the other side, you will miss it. So this is a pretty classic like missed injury. They figured out in the ICU a week later that it's up to double posterior dislocations. Boom. Okay. Yeah, index of suspicion. Exactly. So there are there's one way that actually is, so there's no research on wilderness medicine. There's no one who will randomize to just like disappear into the wilderness. It's a difficult study to pursue. But the Bokor-Billman is validated for wilderness medicine by a small study with a whopping number of 33 patients. And honestly, if I was there, somebody reduced their shoulder, I think that is the most reasonable thing to do without an X-ray at hand or an ultrasound. I would just do whatever I'm comfortable with. So this is the Bokor-Billman that happens to be validated for wilderness medicine. It is not my reduction of choice. I myself would choose either the Davos method. I'm going to try not fall over, which you just ask the patient to hold and lean back, and you assist with holding their leg. I think I have a picture of this. Or like that counter traction handshake mix over, which is called a Ferris, I think. That's what I like to do. Let's see if I have oh yeah, that's the Davos. And I find a lot of patients can self-reduce that way because they have control. You can tape their hands together or hold their hands together so they can fully relax and let their shoulders roll forward, and that's going to help. Supposedly this would work for a posterior dislocation too, but I haven't tried it myself. Or as a tribute to an old attending of mine, just walk into the room, introduce you to the patient, just randomly during conversation, take your shoe off, throw it behind your shoulder, just put your foot in the armpit of the patient and pull. Because the surprise of this, that the doctor who is the attending walks in and does that and talks about the color on the person's sock or whatever, is enough to forego the fentanyl. And they'll just be, what? And it's Dr. Mitchell. We worked with him together. So that also works. And, you know, emergency medicine, because we do hard things and we make it look easy. Okay. I'm regretting this double computer situation. So over to the colder part of it. There is definitely need to worry. I would be worried about this guy. The tricky thing though is that as much as I treated more heat-related injury in Miami, I actually treated some amount of cold exposure injury. It can happen at any temperature if there is enough of evaporation of water to cool you down. And it's not really defined by body temperature, rather patient symptoms. We classify it as mild, moderate, severe. And when the body temperature drops below 30, the body cannot make heat anymore, nor by shivering, not any other way. So it becomes poikilothermic, a fancy word for like being like a frog. You just assume the temperature of the environment. And that can be not good. Also, what I really learned by researching for this is how sensitive the myocardium becomes. So cold, think immediately cardiac issues. Fatal arrhythmias is what's going to like catch you by surprise, unless the patient is frozen to like a deep freezer fish stick. This is where we're worrying about. And the handling is really important. Scaring the patient suddenly, jostling them, moving them, even from laying down to sitting upright, that can be enough to trigger VFib, VTAC badness, disaster. So mild hypothermia, this usually is something that if you're in the wilderness, you can hike out if you have the right support at hand. The main symptom is that you are able to shiver, but you are cold. You have potentially a little bit poor judgment. You have a hard time speaking. Your jaw is locking up on you. You might just want to sit still. You don't really want to walk around anymore to make more heat. And you become really, really hungry. And drinking sugar at this point in time to be able to continue to shiver is really important. As always, remove wet clothing and exchange it for dry. Insulate the patient from the ground and up if they are unable to move around and elevate their temperature. But that is first line things. Walk around, drink something sugary, and maximize whatever you're wearing. It usually goes pretty well if recognized in time. So since, I'm more so in the emergency room than I am for that one time that I went on the nice rafting trip, what I like to remember is just the differential. So the patient should spontaneously rewarm by 1 degree per hour with the right conditions. And if that doesn't happen, or if I always suspect that something is going on, it's not the wrong thing to do. If they look sick enough, that they're just shivering and not turning the corner, then we work them up for the above mentioned sort of differential. You don't have to pursue any aggressive measures with this. External rewarming should be enough to turn them around. And with a negative workup and a patient that returns back to normal baseline, you could much likely discharge this patient population if you excluded everything else and they look good and all that. Moderate hypothermia, though, that's when we start to worry a little bit. They're 32 to 29 degrees. And that's really cold. Like, this is a really sick patient. This is a huge jump in terms of mortality and morbidity. You lose your shivering reflex at 31 degrees. And then at 30, you become whatever temperature you are in the surrounding. There will be mild to moderate hypotension. You will have a diminished respiratory rate and effort because the muscles are so cold, you're kind of freezing up. Pupils will be dilated. You will see kind of slowing of neurological reflexes. And this is where you start to see, the closer you come to 31 to 30, that you will have a risk for VFib. And you start to see prolonged PR, QR, QTC. You have the classic J wave, Osborne wave, which I didn't even include because I think it's like the most useless physical finding. If you like figure out that the patient is cold on the EKG, I feel like you've taken a detour. So forget about it. Forget about it. Remember it for an exam. And this is what I kind of would highlight to manage in the emergency department. This is where the active rewarming becomes really important. We want to jump on this right away before they tire out in terms of respiratory cardiopulmonary status. We have this brand called Bear Hugger. I don't know is that what we use here too? Cool. You know it. I think Arctic Sun is the other brand name, including them just for being equal and not favoring one for the other. You can do warm humidified oxygen, warm IV fluids. Keep the fluids in your like blanket warmer around 40 degrees Celsius. They'll be great, and you don't have to like experimental microwave them in the moment. But you can also microwave if you run out any warmer. Minimally invasive would be, for instance, bladder irrigation. I misspelled instilling warm fluids by NG tube. But this is really labor intense. It depends on what you're setting. If you have a nurse who's willing to do this, this does probably warm you up a little bit, but also not enough for you to drop everything and do this, because it is not probably going to increase the warming by that much. It's all over the place, the research on this. If the patient is stable-ish, I would definitely focus on finding out maybe another cause for why they became hypothermic. That's the kind of the running theme, like why. Also occult trauma. At this point in time, patient is altered enough to maybe forget to tell you that something has happened, and consider a C-collar if you have a distracting injury. All right, this is why we're talking here. So we have completely absent neurologic reflexes and response to pain. We have an unconscious patient. Obviously, acid-base abnormality, pulmonary edema, all of this stuff, high risk for VFib, and potentially even a systole. Okay, so this is when it gets kind of tricky because there's different guidelines everywhere, and it took me quite some time to figure this out. And yes, that's what I want to say here. I think So management here, we have an unstable patient. So we will focus on airway management. We will focus on preventing cardiovascular collapse or managing it if it's already happening. I have a next slide on that. So rewarming takes a ton of time. Have any of you guys been in the situation where you need to rewarm a patient? Real quickly, what was your experience? Wow. So I'm repeating what you said. The legs up to thighs were completely frozen. I'm thinking hard, like popsicle hard. Yeah. Okay. And how stable was he in terms of his mental status?
He was awakeable,
Okay.
but sort of in and out of it. I think his core temperature in the upper body was a little higher
Mhm.
than this. It was
Yeah.
like 30, 32. But yeah, it's the setting in Alaska when they go out of the bar in the morning, early morning, and they fall asleep in the snow. And that's how you get it.
Mm-hmm. That seems applicable to Sweden. So anyhow, the fastest way to rewarm somebody is actually to put them on a circuit, preferably ECMO, but even continuous renal replacement therapy or dialysis. You don't need to run them for like a 4-hour fixed or potassium kidney failure. You just need to run the blood to heat it. Um, Tell me. Yeah.
Yeah, so so if you think about anything that's extracorporeal like ECMO or CRT,
Mhm.
you're moving your entire blood volume outside of your body, right? So it's exposed to air and it cools you down. So being on ECMO, being on CRT will cool you down. The benefit of ECMO is you have a heater that you can change. But CRT, because the flow, so on ECMO, you're flowing 5 liters. On CRT, you're flowing 200 to 300 cc's at
Mhm.
max. So because you're flowing so slowly, you don't have enough time to and the motor doesn't spin that fast, and there's no
Right.
heater in the machine. You actually become hypothermic. So maybe if you cover up the CRT machine, like you can have
But does it give back? Does it have any heating element?
no, which is a huge problem. So like if you this happens all the time, right? Like where we suspect that somebody's infected, but they don't present with a fever when they're on dialysis or
Right.
CRT because they're constant. So if you are ever normothermic on CRT, you're actually febrile.
So when I did research for this in Corpendium, they do recommend, and I'm not sure if I missed that they have like a special machine or some sort of setting that can have the ability to warm. But according to this source, there was an ability to warm. But obviously, ECMO would be your go-to if you have it available. Um, okay. So anyhow, the other things that you could consider is thoracic lavage with the goal to possibly heat left over right. There is absolutely no evidence whatsoever for this. It's sort of a Hail Mary rescue. I have never seen this done myself, but it is a part of the algorithm to heat a patient. And when we're working with an arrest, here we are with a really hypothermic patient. We should not stop resuscitation efforts until the patient is at least 30 degrees Celsius, because you cannot be cold and dead. You can only be warm and dead. And also maybe consider to not continue efforts if the patient is 34 degrees or above and you have no signs of life and no other correctable, cause that you can fix. Also, you can stop right then and there if regardless of the temperature, if you're really hyperkalemic above 12, or any unsurvivable injury identified, if the body is completely frozen, or in an avalanche situation, if the airway is completely packed with snow and there is no sign of life. Okay, this is a busy slide. This is just sort of my take-home points for myself, take it or leave it. These were the management pearls for myself. Definitely anticipate a difficult airway because there is really early in the course this trismus of the jaw, right? Everyone's been cold, you kind of lock up. So I'm thinking a good neuromuscular blockade there is important, and to anticipate it could be difficult to just get in there. To count the respiratory rate for a full minute because it can be so bradypneic or bradycardic that you might miss a pulse. There's a score to assess outcome prediction after ECMO that's called HOPE. I think you can find it on MD Calc, also no affiliation with this. And the most accurate core temp is an esophageal probe, but we usually have a Foley sort of probe. Labs from really cold blood can have lab work abnormalities, like the machine isn't reading it appropriately because it's really cold and stiff or whatever happens. And glucose is typically high because there's insulin resistancy from the cold itself and from catecholamines, but try to not correct this and let it through the roof because it's going to self-correct. This is glucose that your patient will need in their cells very soon. And also build up medication. The liver kind of checks out pretty early in a really severe hypothermia. And you can have buildup of sedatives, you can have buildup of any medication. So consider to cut your dose because there can be sort of a metabolic backlash when they start to warm and the liver start to function. All of a sudden they tank because you gave them benzos or something. And therefore consider half dose induction meds. And I just like these little. There is sort of a controversial topic that I also had to put my head into because the wilderness medicine book and the Corpendium that is more updated had different ideas about this. The wilderness medicine book was really worried about this concept of afterdrop, meaning that when you warm the patient, when you warm the hands and the blood starts to flow back to the core, you will cool your core temp with your hand and foot blood, basically, and that this was dangerous to some degree. But after reading more updated material, this seems to be that this is more of an inevitable part of the process. If you have a hugely unstable patient, maybe choose a time when you're ready to have the fluids bedside, when you're ready to deal with it. But really, what's going to save their life is to warm them. So just don't delay warming them. There's also something called rescue collapse, not to be mixed up with the afterdrop and core temp. We don't really know why this happened, but typically right at the time of safety, the patient completely crashes and goes into cardiac arrest. It has been hypothesized that maybe this is because the waning catecholamines, maybe because they were jostled and airlifted and scared, and that sort of triggered the myocardium that was really irritable. And, we just rewarm them regardless of any of these two things happening. And yeah, I think that's it. And I just found this was so cool. I did not know that a body can recover like this. For instance, 70-minute downtime without compressions. That seems crazy. I had to double check. Those were all referenced in the Corpendium. I had to check in on a couple of these case reports. They were definitely from far out places, but yeah, that's kind of crazy. Crazy. This is the European Resuscitation Council guidelines for hypothermia. They're really busy. I'm not really sure I'm gonna, for the purpose of time, go over them because, you know, they look like they look. But I think my takeaway is that there is actually a slight difference between the European and the American guidelines. We defibs whenever you want to. And you typically give 3 doses of epinephrine, regardless of temperature, kind of go big or go home. Whilst the European guidelines thought a little bit about it and were a little bit more minimalist, thinking that epi doesn't work when your body is that cold. And also the myocardium is so stunned from cold that like you can defibrillate all you want, but will it do something? Maybe not. So they don't recommend to do that if the patient is below 30 degrees, but honestly, you're working with somebody who's more dead than alive. So also like knowing the core temperature at any point in time, like how do I know it's 30 degrees right in this second when I would like to defib them? I think I would err on the side of maybe giving them the benefit of a defib and see if it works, but who knows? Shout out if you have any other smart thoughts on that. Okay, drowning and submersion related injuries. So this is definitely a patient that could be hypothermic with everything that we just spoke about applicable. This is more of an airway and breathing problem though, not as much cardiac arrhythmia situation. So here we have a person who's had stuff in their airway, obviously. And that is really dangerous. So prepare for pulmonary edema and aspirated fluids, even if they're awake and talking, like they didn't drown properly. They're still alive, but they had a drowning event. And this is super important this time of year. I feel passionately about this because this is usually children or swimmers that are not so strong, which is typically children. And I don't know, any emergency medicine doctor will just be like, kids and water is not something that's meant to be. So anyhow, consider BiPAP in appropriate patients that can help with this type of edema. Difficult intubation because they kind of build up like a pulmonary edema, like they fluff up with a little surfactant that they have left. It can bubble in the airway. They recommend ARDS ventilation protocols, at least in the wilderness medicine that I read. And also NG tube. I'm not passionate about my NG tubes like right away, but in this time it makes sense because the person has probably swallowed like liters of water. And for having good lung expansion, decompressing that can be hugely helpful. And also, again, consider your ECMO if the patient is really rapidly declining in terms of ventilation oxygenation. ABG and chest X-ray it up. And patient can definitely come in with a normal chest X-ray or close to normal chest X-ray and decompensate in the next 6 hours. So don't be like falsely reassured by something early. Also a little cold water sort of hypothermia drowning overlap is that adults in cold water submersion, typically an adult patient will asphyxiate before cooling. So this is considered like a normothermic arrest. Rather, and the adults that have had good survival has typically been submerged either with a pocket of air or they've fallen into ice. They can't self-extricate, so they cool down while breathing, and that is when we can call it a hypothermic submersion. Do we know that in the heat of the moment? Probably not, but I thought it was a cool distinction. But children, on the other hand, they can really be considered a hypothermic arrest in any cold water immersion because their large body area will cool them so rapidly that they will be cold before the tissue suffers from hypoxia. And they have a much better chance of outcome for that reason because they cool themselves down. Yeah. Oh, I forgot to change this one. This is what I just said. So that's important to consider. And also maybe give some context why some adults have like miraculous recoveries while most drowning and adults just don't go that well. I felt like that was explained some sort of clinical context for me at least. My clinical pearls that I took away from this was for what I said, the well-appearing patients who present shortly after drowning may look well, but still might end up in the ICU. ARDS can develop even after small amounts of fluid with the loss of surfactant that I mentioned. The chest X-ray will lag in representation. ABG is a great test to do. An initial acidemia could be due to lactic acidosis if you have an anion gap, because the patient has been struggling to swim. So it's kind of like a seizure lactic elevation. And in liver ischemia, it can take longer to clear, but consider that before you like run after your bicarb or, I don't know, do other things. Oh, also a high suspicion for non-accidental trauma and neglect. That's so sad, but so true. I feel like the like 3 drownings that I really can think of during my career that really stuck with me in a bad way. Definitely one of them was not an accident. And also no need for prophylactic antibiotics. I feel I'm telling this to the wrong crowd. This is probably for me and Just, with the US being more trigger happy on antibiotics. Also scuba related drownings. Don't forget about your hyperbaric chamber. And I was thinking all drownings, you C-spine them up with a collar, but the literature says it's really just 0.5% of the drownings that actually end up with a fracture unless there is a clear traumatic injury or trauma to the face, or you knew that they jumped right into a rock or whatever, but just the undifferential drowning, it's not that common. All right, jumping into heat. So this is kind of another population that have really wide sort of end of the spectrum. So we have 2 distinct populations where one is the healthy athlete who overexerts themselves and they can become really sick. This is called a heat exhaustion. They become nauseous, they vomit, they are hypotensive, but they're not altered just yet. This can turn into heat stroke. And the typical patient that has a heat stroke is any person who doesn't have the physical or mental capability to seek safety when they need to. So typically more elderly than anything, but also children, infants who are not able to sweat like they need to, or who might just not physically able to like move themselves into safety. And obviously, a very young athlete is going to have a whole lot better outcome than an elderly patient who were already septic and then fell asleep in her bed and couldn't get up in an apartment that then lost power and heated up, and it's just badness on badness. So yeah, definitely when they do research on this, it's hard to find like good survival predictions for that reason, because it's a pretty wide range of patients. Always good to keep the differential in mind. My previous lecture, I made a little plug for my baclofen withdrawal that can come with fever, which kind of fits into the tox emergencies in one way or something like that. I guess I should have put it on here. But anyhow, there's a lot of other stuff that can cause an elevated temperature. So keep that in mind. But usually it's pretty straightforward. Usually paramedics will tell me we went into the apartment and we couldn't stay. Like it was so hot, or we went into the car or wherever they were and it was incredibly hot, or just the fact that the patient looks like they've been laying there for a long time. We have our mild heat-related injuries. I honestly see this quite often. I haven't even thought of it as a heat-related injury, rather just like annoying things that I need to deal with. But like the classic, like, oh, well, I've been out all day and now I have a sunburn, versus maybe the heat rash that kids typically develop. It's this little morbilliform red dots called prickly heat rash. Kind of immature sweat glands or plugged up sweat glands can look like that. I think everyone knows about heat cramps and heat edema. We're not going to hang out on this slide for too long. These can be go home after some therapeutic face-to-face with a doctor. So I want to start to think a little bit about stuff. So this is usually a healthy person who is physically exerting themselves really hard beyond their capacity. That means that it can happen both in normal temperature, like today, but also more common in hot environments. This is a great prognosis because the second this person stops exerting themselves, drink some water and calm down, you will have a body that is able to cool itself, that is able to continue to sweat and seek safety. So just fluids, rest, stop exercising, minor cooling measures like putting some wet rags on your face, things like that. But beware, because heat exhaustion can turn into heat stroke, which is characterized by altered mental status. And when we've entered into this category, it's bad news. This is a full-on medical emergency. It's high mortality. Cooling instead of fluids, but also fluids. we want to undress the patient. We want to spray with water and set up a fan. And immersive cooling, meaning dunking them in ice water, is also probably more effective. But for a really sick and stable patient, you don't want to be running a coat in a bathtub. So it's a balance, I guess. But for instance, in like a big event, if you have a big concert, I don't know, Coachella, whatever, partying in the desert, they usually have ice tubs where they actually put people in because it is the fastest way to cool and it is safe. And goal temperature is 38 degrees. That's when we start to feel more good about ourselves. And also a part of the heat stroke, I think I forgot to say, it's a temperature above 40 degrees Celsius. And the CNS dysfunction can be just like frank seizures, like they're just comatose, but it can also be like ataxia, irritability, confusion, change from baseline. And cooling early is survival. So you don't want to, of course, when you have the patient, when you receive them, you go through your differential and you think about, could this be something else? Sorry, my computer is, I think I got some like stuff on my little mouse pad and it's not moving. You of course want to think about all your above mentioned sort of differential, but it's safe to start cooling. If the patient is hot and you think there was environmental factors suggesting this, just start cooling them. If you cool them down to normothermia, you're probably not going to harm them, even if it ended up being sepsis and a seizure. So just do it. With the really sick, warm patient, we want to check a few things. CBC, a CMP for electrolyte derangement, renal failure. I think 30% of really severe comatose patients go into renal failure. We want to check in on coagulation factors and partial thromboplastin time because DIC is actually prognostic for survival, or I mean, not prognostic for survival. The lack of DIC is prognostic for survival. And mortality range is high. It's between 10 to 50% with potential for permanent CNS damage, which is really scary. And also, I loved how you just pointed out in your lecture that trauma is a preventable illness and think about it as such. This is not just an accident that happens once in a while. It's a preventable illness. For instance, in the US, all new cars have this really silly alarm, but I also love it, that says check in the back for children. Like people actually die from this by being stuck in places where they shouldn't be. And oh, okay. Finishing off with my last little nugget of, I think I have a couple of minutes for this. It's short. Retrobulbar hematoma. So according to our packing list before, we can splint stuff, we can treat some infections, we can do a couple basic things. Maybe we brought a suture kit. And let's say somebody suffers facial trauma and they start to lose their vision. This is something that you could perform if pressured to, and potentially save someone's vision in that eye. But it's also a little scary, so then you might feel like this. At least that's how I felt when I had to do it. Okay, so this is the basics of it. You need your hopefully anesthetic, syringe-free anesthetic. You need your scissors from your lag repair kit, hopefully a blunt tip scissor, but you know, you do what you gotta do, and a hemostat. As this picture suggests, you numb up the patient at the corner of the eye. You will kind of crush the tissue to make it bleed less. You will cut sort of pointing a little bit downwards because the eye has two tendons, I guess you could say, that holds it in place. And I guess I jumped to conclusions that the problem with this is not just that there's a little bit of blood behind the eye. This little bit of blood creates a ocular compartment syndrome that will pressurize your optic nerve and you will lose vision. So crush the tissue, make a cut, find a tendon that kind of hangs out just behind the ridge of the bone. There's a little violent stringy thing there sitting on the eyeball. You cut it and the patient does better. Seems so easy, not that easy to manage because it's one of those lovely procedures that we do so rarely that when you have to do it, it turns out to be tricky anyways. But if we can do it and save someone. That's a good thing. And this is another camping trip with my dog. Any questions? We'll wait for the microphone, but I would love to hear your question.
How much we have time to do like this sub compartment syndrome and
You know what? That's an excellent question. I know that you can lose vision within. So it depends on, in the emergency department, you have a pressure, you are able to check pressure. So a pressure above 40 with your intraocular, or your, what are they called? Pressure thingy, the thing that you tap on the eye, that would definitely alert you to do it. It also depends on how quickly the patient presents. Have they already lost vision in that eye? You're working with salvaging things. You're going to do it as quickly as possible. If the patient's unconscious and you don't know, you also want to just salvage and do it as quickly as possible. If you see it on the CT scan and the patient is like, oh yeah, you know what? It kind of looks a little funny and maybe it really hurts, and they're able to tell you, and they sort of have questionable vision findings, maybe you have time to wait for an ophthalmologist to show up and help you. But the second you have vision changes, I wouldn't really think twice about doing it because the optic nerve is kind of sensitive. It doesn't like to be played around with. Did that answer your question?
no, thank you.
I don't have a hard time limit. I actually don't know. But if anyone in the audience have like a, yes, the evidence base is X amount of minutes, I would love to hear it. Do you know? No? Okay. But you have a question? Oh, okay.
Just a quick little thought. So do you have any, in your reading, did you come across any literature or data to talk about targeted temperature management in your hypothermic patients who have suffered a cardiac arrest? Like how quickly are you warming them? To what temperature are you warming them? And how does that play in with TTM?
Excellent
brain?
question. I think I have that somewhere in my speaker notes that I kind of went off my track with. So what I gathered from Corpendium, which is like the latest, like this is not necessarily what's written in your textbook that comes into print, but this is more recent stuff. So sometimes that means that it changes because literature comes out and comes out. But according to what I read there, you should sort of go towards your temperature targeted post-cardiac arrest temperature, the same protocol, the same temperature you would shoot at, you warm them to that degree, and then you slow it down. So it's okay to warm them to a degree. I mean, let's say you aim for 34, right? 36 is usually what I do because that's in my medical patients I have, I don't know, sometimes 36 is usually my practice. But yeah, between 34 to 36, you can sort of calm down and stay there is my understanding. If there is different practice in Sweden, let me know. Any other questions? All right. Well, thank you all for coming. I hope I inspired you getting out there.